Great. So Yvonne, thank you for agreeing to meet with us. There was a question that came to me, and Michelle, Kim, I'll start us off, and then you can fill in the blanks. There apparently was a definition change with agency affiliated counselor, and it was the understanding of Sarah when she first approached me that they were having a backlog from their youth mobile crisis. I think it was specifically that there were Medicaid individuals who had straight Medicaid. They were having to put with their fully licensed mental health counselor as opposed to their agency affiliated because they were not getting reimbursed. And so for me, it didn't sound correctly because I knew that the MCO paid for it, managed care organizations paid, but the fee for service seemed like fee for service should pay for it. So when I reached out, that's when we realized there was a rule change. So they were interested, Catholic Charities was interested in learning more. And in that same vein, we asked Dell from Renew and David from Okanagan Behavioral Health if they were interested in learning about this definition change and what it meant for their organizations, if they would like to join the conversation. Hence the reason we're all here together. So, Kim, did I represent that well enough, or would you like to add some additional information?
That's great. I think it was just for us, for me at higher levels, we were serving these youth in mobile crisis, and we weren't able to get them into therapists. So Michelle and Jason, I think, are our only licensed mental health therapist, and their caseloads are so full and have waiting list. And so we didn't want to lose them. So I just went to Wendy like, what can we do about this? What is the solution for this? And so that's when this whole conversation started. So that's high level for me why I opened the conversation.
Okay, Eliza has her hand up, so I'll let Eliza.
Yeah, before we kind of jump into it, I just want to clarify because we want to make sure as the healthcare authority that we're appropriately offering the information that we can. So is the intention for us to clarify the differences between the agency affiliated like definitions and like between a registered, a certified, and a licensed? Is that came from this what's called the 1724 legislation? And the reason I just want to I want to have that clarity is because we get those definitions from Department of Health, right? And then we translate them into our Siri guidance or our billing guidance as like provider types and whatnot. So our roles are pretty distinguished from Department of Health. So I just want to clarify the ask.
I think that's what we're looking for is when you said you translate that to services, like that's what we're looking for. I mean, we can read the definition and we kind of understand it, but yeah, how does that translate to service delivery and who clients can see?
Mm-hmm. Okay. And we're looking on, so Yvonne's role is with fee for service. And then my role is with anything like relating to managed care and for the service encounter reporting instructions utilization or Siri utilization. So which direction are we going? Because their providers and things are a little bit differently represented in those guidance documents.
I think that's a good question because right now it's all like a big fog. Like I don't even know how to answer that because I'm not quite sure.
When you guys submit encounters, are you doing or are you submitting when you're submitting your claims and your information, who are you submitting it to? And are you guys a behavioral health agency with the Department of Health, for example? Are you a licensed behavioral health agency with the Department of Health? And therefore, do
Yes.
you have contracts with the managed care organizations to provide the services that you are, whether that's mental health or substance use?
Yes.
Yes. So that to me is lending more towards using the service encounter reporting instructions, which is the managed care organizations, for example, would require you to submit your behavioral health encounters to show what services you are providing.
So our billing department takes care of, like they do all that, right? We just see
Sure.
clients. from our perspective, so what we've been doing is if somebody comes in, if a client comes in and they're enrolled in services and they have HCA insurance, they have to see a licensed provider.
And
Is
when
that
you say HCA insurance, what are you referring to Medicaid?
not Molina or coordinated care, any of those,
Okay.
but straight HCA?
So that's
So,
going to
like-
be a big distinction that Yvonne can clarify, because Medicaid is what would utilize Siri, but fee for service would be when there's a core provider agreement directly with HCA, and I can let Yvonne speak to that.
So what we call a HCA Medicaid is Apple Health clients without a managed care plan. And that's otherwise known as Part 2 of the Mental Health Billing Guide. And so I don't know who said that you couldn't see people if you were just licensed, because usually the crisis team has a care team. And so a licensed mental health professional, a mental health care provider under the supervision of a mental health professional, and a certified peer counselor can be on a crisis team, and also an SUD professional. So it's like all those are billable under the fee for service program. So I don't know who told you that they had to be licensed. So I'm assuming when you say fully licensed, you're meaning a fully licensed LMHC, social worker, marriage and family counselor. So all the provider types that are in Siri are also allowable in mental health Part 2. So
when you say mental health Part 2, can you tell me what that means?
okay, I'm going to share my screen.
And I just want to clarify that we're talking, I see that Dell's had his hand up for a while too.
Oh,
I just
sorry.
want to clarify that we're talking about the therapy after the mental health therapy after the crisis. So we understand the MHP and all of that for crisis, but moving out of crisis into that next step after that period of time that they're with our crisis team, then we want to get them to with a mental health provider. That's what we are focused on here at Catholic Charities.
Right.
How do we do that?
And Yvonne, I'd like to turn it to Dell, but I would like to set some foundational building
Okay.
blocks
Okay.
before we dive into showing documents.
Okay.
But go ahead, Dell.
Oh, I was just confused on what occurred. It sounds like someone came through crisis, then a crisis referral was made to an outpatient service provider, and that outpatient service provider has a contract that's directly with HCA for these services for individuals that aren't enrolled in Apple Health, or they don't have a managed care plan, but it's still considered Apple Health, so straight Medicaid. And they got assigned to somebody that was agency affiliated, and the organization did not get paid for that service, or they were told that they could only be seen by a licensed provider.
We were told at some point that they could only be seen by a licensed provider. I think we were getting reimbursed, but there was a different, Darlene Riker is our credentialing specialist, and she had some type of message where there was something that she had to submit to the HCA. And I'm sorry, because I feel like all above my head in terms of the acronyms and all the programs, and like, give me all the foundational things, please, because I have I don't have a strong context here. And so it wasn't that we weren't getting reimbursed, but there was something on the licensing side of that they had to be in outpatient services for therapy enrolled in seeing a licensed provider.
Okay. Thank you. That helped clarify, because I was just feeling a little confused on what occurred.
Yeah, and it actually hasn't occurred on our behalf. We're trying to be proactive so it doesn't happen, so that we're able to serve our youth.
Okay.
And that
So
we have a broader capacity to serve our youth. Well, all of our clients, but.
And it looks like David has a comment, and then I'd like to set some foundational building blocks if I can.
Thank you. My experience with Medicaid is it doesn't require a licensed therapist. I've not run into that with fee for service. Now I know that, and Dale, you may have heard this in the Washington Council meetings about the SPA agreement, and their SPA agreement only says licensed people are allowed to provide service, and they call those shadow services. Now, I don't know if that's what we're talking about. But traditionally, unless it's like a private insurance like Kaiser or somebody like that, we've credentialed them and they had to be licensed. But through Medicaid, I haven't really run into that where they had to be licensed.
Sure. So this is where I think some of the foundational building blocks will come into play. So what Yvonne is showing on the screen, and Yvonne, I don't want to get too far into that and detract kind of from some of these building blocks, and then we can circle back to what's on the screen. But I think the piece, so Medicaid is built within the Washington State Plan. So in acronyms, you'll hear that called SPA a lot of the times. And there's a section within that called 13D. And 13D is what we have both in the Service Encounter Reporting Instructions, or SERI, and what's in the Mental Health Billing Guide Part 2. The Mental Health Billing Guide in general is for fee for service. The Service Encounter Reporting Instructions, or SERI, is for our managed care organization, those who have a managed care plan. Let's just make it simple. So without managed care plan, fee for service; with managed care plan would be SERI. Part 2 of the Mental Health Billing Guide and SERI reflect directly what is in 13D of the state plan. So the service modalities that are located within SERI and allowable within SERI and the Mental Health Billing Guide Part 2 are what is allowed in our state plan to be paid for or by Medicaid. So that's where that foundational piece comes from. With that said, what our state plan allows for is two specific provider types, which I put in chat. So there's the mental health professionals, and then there's the mental health care providers. How we've translated that into services is we've taken the Department of Health licenses and credentials, and we say this person qualifies as either a mental health professional or a mental health care provider. So we have a crosswalk on page 135 of SERI that actually shows. So if here's a DOH credential, here's the Medicaid state plan that it reflects. Here's what it looks like within our billing guidance or SERI, and is this person a mental health professional? All of the services, they will say in their descriptions, they have to either be provided by a mental health professional or under the supervision of a mental health professional. So a mental health care provider, for example, has to be providing services with some type of line to supervision by a mental health professional. The mental health professional, you'll see the definition here on screen, and then also what I put in the chat. So that's going to be your psychiatrist, psychologist, PAs working with supervising psychiatrists, fully licensed LMHCs, LICSWs, etc. Whereas the mental health care provider is a person who is a bachelor's level in a related field, and who usually is working under an agency affiliated counselor registration. This now it has expanded to, there's also the agency affiliated registered, certified, and licensed. The licensed and certified per DOH can be mental health professionals, right? Whereas the registered remain as this mental health care provider. And those again translate into the services being provided. So a good example is a peer support specialist. They are considered a mental health care provider, and they're usually a registered agency affiliated counselor with DOH. So those are some of the initial foundational building blocks that we want to work from. So what Yvonne has on the screen, and I see your hand, David. What Yvonne has on the screen is again the Mental Health Billing Guide Part 2, fee for service. which is reflected in the state plan, section 13D, Medicaid allowable services. Go ahead, David.
Thank you. And not to complicate this conversation, but there is talks about the bachelor's degree or the 2-year education and 2 years experience that going away in the state plan as well.
Yes, we definitely that has been advertised. We are looking at that, but that is to adjust to what DOH has as the requirements for the new agency affiliated levels. So that's now for the registered, the certified, and the licensed. So really, it's just going to take away the minimum qualifications being a BA or an AA. Instead, they would have to meet the DOH agency affiliated credentials, which are now the registered, certified, and licensed. And so yes, that piece will go away, but the mental health care provider type will still exist with the subsequent providers still falling into that category. So that was a lot of information. What can we offer for clarification, and then we can go from that point. So I would say so for example, whenever there's a service being provided in so Yvonne, can you go to a specific service like an individual counseling service, for example? So you'll notice we're in the part 2, which is the specialized mental health services for Apple Health clients without a managed care plan, or they have behavioral health services only, which is through a managed care plan. And so what we'll offer here is like, so for individual treatment, this modality description comes directly, it reflects what's in our Washington state plan for individual treatment services. And then if you go down to the actual codes that would be a part of this.
I'll go to the fee schedule.
Because the codes are not embedded here, correct, Yvonne?
They're right here, but they're
Well,
not
yes, right here.
They're not like Siri.
Nope. So then you'll see the state plan modality there on the left. So individual treatment services needs to have this code and this part. When it comes to the provider types that can provide this service, Yvonne, I'll let you speak to that.
So individual treatment can be done by a mental health professional within their scope of practice.
And where does it outline that?
Well, we just have it under definitions. This is a work in progress for the mental health billing guide, because we don't get as in the weeds as Siri. So as I've been updating the guide, I've been adding things, but so a mental health professional within their scope of practice, because we don't really like.
And what that refers to is, so when it has the definitions, the expectation is that you as the agency would know if you have within your contract or your ability or your service realm to provide individual treatment services and the appropriate providers to provide it that coordinate with being a mental health professional, and with the expectation that would encompass, right? And so that's kind of how this piece is outlined in the mental health billing guide part 2.
So just a little bit, like for mental health part 2, we don't use servicing on our claims. It's billed as an agency, and it's always billed with, so the agency should have the 261QM0801X under their under their profile in provider one. And then the codes that are listed on the fee schedule, it's always reported with the TG modifier first. And then this will change in the future, but right now you're only billing as an agency. And then you would bill for your services and make sure that that agency affiliated or the mental health professional or the mental health care professional are billing within their scope of practice. And then that's where we would. So an agency affiliated is allowed to do a lot of services. But the thing you would have to like make sure your mental health care professionals are billing like within their scope. But you said crisis was the like it was getting
The services after post-crisis is what I heard. So maybe let's pause there and see what from there, what additional questions do you all have, or what direction do we need to go to make sure you get the need clarified?
Yes, you are correct. It's post-crisis. And so are these rules and this coding, is this all Medicaid? Because one of my big questions was private pay, and that's where our big gap is. Are we going to talk about that at all? Is that?
Unfortunately, private pay does not, that like, you're talking about when the person is paying their own way, like they don't have no private insurance.
No, I'm not using the right. No, I'm not using the right. It's when they're not Medicaid, Medicare.
They're commercial.
So when they have commercial
commercial,
insurance,
sorry.
so when they, so unfortunately that is not our realm.
Okay.
The private insurance, that's generally through the Office of Insurance Commissioner. That's who would be the first contact to have a discussion about concerns related to private pay. We only deal, as the healthcare authority, we only deal with the Medicaid, Medicare, and behavioral health agency service organizations piece of things. We coordinate a lot with the Office of Insurance Commissioner to make sure we have some alignment when we can, but we do not have any say over the commercial plans at all.
To kind of circle back, so I was going through my email to see if I could find like the original message, and so it looks like this was in the beginning of October, that our credentialing specialist had sent an email that said that clients that have straight Medicaid can only be seen by providers that are fully licensed: LMHC, LIC, SW, MD, ARNP, PsyD.
That could be based on the code, I wonder.
Well, and it could be, that's true with part one of the mental health billing guide. Like part one of the mental health billing guide is for independently licensed, or there's some clinics out there who have only have fully licensed staff, and they have to be fully licensed. We're just now starting to add associates to part one, so that may have been where the mix-up was at, because part two is like that's part one is 6D of the state plan, and part two is 13D of the state plan. And the state plan for 13D they have certified peers, agency affiliated, like Eliza said.
There's more options. I would say, part one is for those who kind of hang their own shingle. They have private practice, those type of things. And also those who are embedded in like medical clinics and things of that nature. And it's for less, I hate to use it's for less specialized services. So our behavioral health agencies do more of the, for lack of a better term, like higher acuity, right?
Mm-hmm.
Whereas someone in a private pay setting would not necessarily do the higher acuity services. So that's going to be something. It also could be, so the part one is a really good point, Yvonne. I wonder if that was part of the mix up, because that is the requirement for part one fee for service services. The other piece is it could be like dependent upon the code and the providers that are allowed to provide that code. So sometimes it cannot be below an element. Sometimes it can't be a master's level with that's agency affiliated. Like on some of our codes in SERI, they have to, it's only those who are fully licensed and up as the mental health professionals. That's pretty rare, but that is part, that is on some of the codes. So having the actual code in question is super helpful to us when possible.
Yeah, I like to look at TCNs and codes so I can navigate through the weeds. So
Okay.
And just to clarify, Liza, the 3 organizations on the call today are all our county behavioral health agencies. So they are the ones who are providing that more specialty behavioral health service within our counties. They're not private at all.
Yep. So that's why we're really focusing on the mental health billing guide part 2 and then the SERI guide.
I'm curious because when you showed this code and it was asked, how do you know who the provider is? And it just said within the scope, the professional within the scope, how are the agencies supposed to know if it's agency affiliated or fully licensed? Because now you're saying, well, it depends on the code.
well,
So
go ahead, Liza.
So to clarify, when I'm saying it could depend on the code, I was meant more for like when it was mentioned that it had to like there are some codes that this is within SERI, within the service encounter reporting instructions that say here are available provider types for this code. Otherwise, in the mental health billing guide, it's mental health professionals are what is the outline practitioner within this. So if you go back to that definitions list, Yvonne. It'll say right here. And if you look above that, can you scroll up, Yvonne? You do not have the mental health care provider definition.
I noticed that when you were
Yeah.
saying.
Well, and that's what I'm saying. So we really focus here on the mental health professional definition. And that's how it should, that's how we look at that service being provided. But that should also, Yvonne, you were going to say something prior to me jumping in there.
I would also rely on the who's credentialed to know what their scope of practice is. I mean, I know as a registered affiliated counselor that I know what my scope is, what I can do and what I can do. So, and just really going to DOH and asking what that scope of practice is for those credential types.
Mm-hmm. Yep, it's a kind of a hard, so one of the things at the Healthcare Authority, we have a really strong line that we have to uphold where we cannot tell providers or MCOs or anybody how to bill. So we have to hold the line there. So we really can't, we as specific as we would like to be sometimes in these guidance documents, they have to serve as guidance. And we really can't be as directive or as specific. Like, so we can't go and say, you as an agency affiliated counselor can do this, this, and this, and this, and this, and then, and this. We have to give the broad scope and put the onus on the providers and the agencies to, again, like Yvonne said, go to DOH to know that scope of practice, know kind of the state plan and what's expected when it comes to Medicaid rules. And then we can like support those conversations with, this is what's in our service encounter reporting instructions. So, and here's what's in our mental health billing guide. And with the scenario that you provided, what we can offer is that this is what we have as allowable per the Medicaid state rules.
Yeah, and I'm just starting to, this is work that I'm doing because I just got the mental health billing guide about a year and a half ago. And so what I've been doing is I've been trying to, every time I add a new modality, I've been listing the, you know, what's doable within that modality. Individual counseling was kind of more broad, so, but I can definitely work on that and make it more clear. But, and if you see anything, please just email me. You know, if you have any questions, if it's not clear, I'd be glad to look at it and fix it. So, but I've been trying to, as I add medication I just added medication management. So I listed the provider types that were included in that. Medication monitoring, I did that. So this is a work in progress for me. So if you ever have a question about it, just please email me.
Thank you,
Go
Yvonne.
ahead, David.
I know there was a conversation around, and Dale can probably chime in if he wants, but there's a conversation around crisis and how that works. And actually, it's been a while since I've heard of the conversations around crisis providers, the BHO, ASOs, recouping costs from the private insurance companies through the crisis system. I know that that's the direction. And I think that may be some of the confusion as well. Like, you can provide crisis services and not have a licensed person, but if you provide crisis services and they're not licensed, can you bill private insurance companies for that service? And if you do bill that service, then that service then becomes, depending on how you're paid, you then have to repay BHO ASO because you've already been paid for that service and now you're being reimbursed again. So there's some complexity in there, and I don't know where that is going to end up falling ultimately. But as I think from there, as they transition to outpatient services, I don't my experience in fee for service and in other organizations, you don't have to be licensed. You can provide those services if you're MHP, outpatient services. And if you want to provide service for somebody like Lena or United Healthcare, their private side, or some of those, or say Kaiser, where they're going to require a licensed individual for your contract, then you would have to put those clients in front of licensed people.
Correct. Yep. We don't have the only piece where we say this has to be a specific provider type is if it lands within the definition of an MHP or the mental health care provider, and whether or not the provider types that are defined within those two state plan types, that's what we translate to services. And what I will say about the private side when it comes to crisis is that was a bill really called 1688, and it has been implemented, and at least within for crisis services, we do have a whole guide for our we interface with the private insurance plans just for crisis. So Kim, I have to retract a little bit there. We did work on a joint plan with based on the legislation for private insurance plans because they do have to take up the cost for crisis services, and there is actual guidance for them to do so. And so it is expected that the private insurance plans are paying for crisis, and it's pretty specific of when something is a crisis code and when it starts translating into other services, because for many other services, an intake has to take place first before any other services can be rendered. And so, whereas crisis is not one of those. So there is, as far as the 1688 legislation and crisis for private insurance plans, that is implemented. And we've had expectation guidance up for the crisis for the private insurance plans since last year.
My understanding was the same as David's on that, as far as the MHP being able to provide those services under any of the Medicaid plans. And then on the BHO ASO or the BH ASO aspect, my understanding with the crisis services, that those that we're seeing on a private basis are being on the back end through the ASO, working with the private insurances to make sure they're reimbursing for services that are provided to the private insurance. But so yeah, I just wanted to let you know that I do concur with what David was saying. We both understand that.
Mhm.
Any other questions, clarifications for Yvonne or Eliza?
Not right now.
Eliza, would you mind putting your contact information in the chat? That way, if anyone on this call or Sarah has additional questions, they can reach out with you and Yvonne.
Yes, what I will say is that the best way to do that is actually going to be through our program mailbox. And the reason I say that is because then an issue number gets assigned and it still will get to Yvonne and I. But the program mailbox will actually allow us to track it better. And to ensure that we have some accountability on our end with an issue number. So that would be the best way to ensure we are answering your questions and we pull in who's needed. So let me give that number. Or excuse me, not the number. Let me give that email.
I think, Wendy, I think that's the email you came through, right?
I honestly don't know. It's whatever Teresa Claycamp gave me when I
Yeah,
was
so
with her.
yeah, so Teresa, yep, we're really
Okay.
moving for inquiries to go through the mailbox so it can be better, so we can do our job of tracking it and pulling in who we need to. But nonetheless, we are very much known as the go-tos for Siri and mental health billing guide and all those type of questions. So it shouldn't get routed to various locations.
All right, one last call.
Michelle, did you go through the provider customer service when you got that answer?
No, quite honestly, I'm a supervisor and I see clients, and so I just do what the billing people tell me.
Okay.
I don't follow up with those directly. I just say, okay, right?
I just know I wouldn't have told Catholic Charities that they had to be fully licensed. So I was like, where did that?
No, and I think if and if there's any concern about billing, discrepancies in billing, we're happy to have those conversations with any of your billing departments or anything like that, because while we have to have that strict line about how we can't tell people how to bill. We want to support in the understanding of those foundational building blocks and how these guidance documents are supposed to read and supposed to offer that clarity. And we update those often. I would say, well, for Siri, it's about twice a year. Mental health billing guide is quarterly. So we try and do this and get feedback as regularly as we can. So just wanted to throw that out there.
Yeah, and if you read anything in the mental health billing guide that does not make sense, just email me and I will, because it's a work in progress. So I work on it quarterly and see little things that need to be fixed and updated. So please.
And we
reach
try
out.
and stay in alignment. So definitely use that program's mailbox, even for questions for Yvonne. So if it has to do with Medicaid, just so that we try and tag team those as often as we can. Are you good with that, Yvonne?
Yes.
Okay.
And so much of our directives have come from our credentialing specialist that Michelle mentioned earlier. And so I think for some of our next steps will be for us to connect her with you and maybe have some of these same conversations. So she's very clear on it to help fill some of these gaps.
Yep, happy to do so. I did include the service encounter reporting instructions. And Within that, there is a provider type crosswalk. Again, that's specifically related to Siri, and our BHAs do use this, but not in the context of how you all are describing having the HCA Medicaid and the direct, like the core provider agreement. So this is more for those who contract with our managed care organizations for services. But nonetheless, there is a provider crosswalk towards the back of that that could help share some light as well.
I'm curious, did you have Siri before there was Siri, SIRI?
You know, I joined HCA in 2020 and Siri guidance goes back to 2013. So I don't, and that's the last version I see, but it may have existed before that. So I don't know. Which
Got a
came
little
first,
confused.
Apple or
Yeah.
the HCA document?
Love it. Well, I really appreciate your time.
Yes, thank you
Very-
so much.
Yes,
Yeah, I
always a
appreciate
lot of information. Oh, sorry.
I was just say I appreciate that, Wendy, you took the time to record, because Sarah will definitely want to hear all of this and
Mhm.
help Michelle and I interpret it and decipher next steps for us, and for Dell and David for leaning in with us and being collaborators.
Yes, thank you very much.
We
Thank you.
appreciate your work over
Thank
at Grant
you.
County, so thank you.
Yes.
Thanks for including us. Appreciate it.
Yeah, no problem. So for next steps, I'm going to, I'm on the road now, so I will probably tomorrow morning will get it uploaded in a way that you guys can review. I'll probably just put it on YouTube, because to me, that's just easier for everyone to be able to review. Send it to your credentialing or billing persons that you think that could benefit from this information. I will also include the links that were in the chat, as well as that email address. So if you have follow-up questions, you can individually, after your people have reviewed this, be able to follow up with more succinct questions. And if Michelle, if there was a billing code specifically that your credentialing person has as an example, may be helpful for the HCA team to be able to backtrack maybe where that issue potentially came from.
Yeah, I'm kind of scrolling through my emails now to see if I can find some of that.
Yeah, I'd be glad to look at it. So see what's going on.
And I do think it might be worth as next steps for us at Catholic Charities, and definitely with our other partners, is next step is the Office of the Insurance Commissioner. So Wendy.
I actually have private insurance already on my list to start reaching out to. Primera's first, just because they're the largest in our region. I just needed to get this one under the belt, and we'll get this one solved and clarified, and then we'll move on to Primera. I've already researched who I have to reach out to, so I will reach out to them and find out what's their deal with agency affiliated and why they're not accepting that as a credential for you guys to bill under. So we'll see.
That's great. Yeah.
And then if we have to take it to the Office of Insurance Commission to say, hey, if it's good for a Medicaid client, it should be good for anyone. We shouldn't be segregating them out. So
yeah, and that's one of my big concerns. And as we all know right now, that crisis is increasing, our clients are increasing, and then what do? We just let them go. So these are some great things I think that can help us move forward in serving them, but we still have that other population to take care of as well.
Yeah, and we're widening the gap of behavioral health issues for those individuals who have private commercial insurance. So and not having access to care. So
yeah.
Yes.
Excellent.
And definitely appreciate you bringing us in. Can appreciate having been boots on the ground for the first 18 years of my career. Really appreciate what you all are doing.
Well, thank you, everyone. Happy Monday. Hope you're enjoying the spring weather. Go plant some flowers.
Yes. Take care, everyone. Bye-bye.
Thank you.
Have a
Appreciate
great
you
day.
all. Thank you.